Good morning, everyone, and welcome to Tyro Multidisciplinary Seminars. I would like to just acknowledge the fact that we are now celebrating a 3-year anniversary of having started this program back in March of 2020. And we have just shy of 150 recorded sessions that are available on the Tyro website. So we welcome you all to this morning's program, and also welcome you to take a look at the Tyro site and get access to just a wealth of information related to thyroid cancer and thyroid nodule management. So for those of you who did not get the memo, this morning's program is slightly changed from what our original program was supposed to have been. Those of you who thought they were going to be listening to a program on pediatric thyroid cancer, the original presenter had a last-minute conflict, and so we will be circling back with him at a later date. But we are fortunate to have Drs. Brandwein and Doyle, who were scheduled a little bit later in the spring, move up their presentation related to cutting-edge research on tall cell variant of papillary thyroid cancer. Dr. Brandwein is a part of the Tyro programs and has been a frequent presenter. She is the site chief of pathology at Mount Sinai West and director of the Head and Neck Pathology Fellowship. She has had a remarkably productive academic career with over 130 manuscripts in peer-reviewed journals, 50 book chapters, and 3 single-author textbooks. She is widely recognized internationally for her work on the World Health Organization classification panels, as well as the panel that completed the 8th edition of AJCC staging. She is also currently an NIH-funded investigator holding an R01 related to her work in oral cancer. We are joined this morning by her co-conspirator, Dr. Scott Doyle, who is an assistant professor in the Department of Pathology and Anatomical Sciences at the University of Buffalo. He received his PhD in biomedical engineering, where he developed a computer vision and machine learning approach to identifying and grading prostate tumors with digitized whole slide images of H&E stained needle core biopsies. Dr. Doyle teaches a course at the University of Buffalo on machine learning for biomedical problems aimed at bringing engineers and biologists together to create novel approaches for analysis of complex problems. And this will be the essence of the discussion this morning, the conundrum of trying to identify tall cell variants in a more systematic way, and applying some of Dr. Doyle's expertise to that problem. And this morning's discussant is also an individual who really needs no introduction. He has appeared on Tyro on numerous occasions, and he will be the discussant of this morning's presentation. Dr. Ronald Ghossein is the director of head and neck pathology at Memorial Sloan Kettering Cancer Center. His major research focus is on improving classification of thyroid carcinoma. So the conundrum of tall cell variant is really right in his sweet spot. He is the senior author of the landmark article on the reclassification of non-invasive follicular thyroid neoplasms with papillary-like nuclear features, which really profoundly impacted the world of thyroidology. Well, with that, I'd like to turn over the program to Dr. Brandwein, who will start. And as always, I encourage all of our listeners to send in their questions, of which I am sure they're going to be numerous, and I will do my best to field them before the end of the hour. So to Dr. Brandwein-Weber, Dr. Doyle, and Dr. Ghossein, thank you for stepping in last minute to move up this program. Thank you.
Okay, so today, Scott Doyle, who is now associate professor, and I'll be presenting our ongoing work on tall cell variant of PTC. I'm the opening act for Scott, and bringing this home in the Jimi Hendrix position is Ronnie. So every pathologist who's signing out well-differentiated thyroid carcinoma needs to be aware of all of the reporting elements of the American Thyroid Association risk of recurrence schema. This is a scale of aggressive elements. And in this scale, which is basically standard of reporting, is a standard reporting element, is this feature of aggressive histology. And so aggressive histology refers to tall cell variant PTC or hobnail cell variant and or columnar variant. The latter two, columnar and hobnail, are very rare. And of course, tall cell is more common of the three. So I'm going to be limiting, we're going to be limiting our discussion to tall cell variant of PTC. And so moving up a patient from low risk to intermediate risk or beyond has important prognostic and treatment ramifications. This is a call that needs to be made every time a PTC is being signed out. And a call of tall cell variant PTC may move the patient up from a hemithyroidectomy to a total thyroidectomy, and may be a reason that the patient has to receive radioactive iodine. So this is a high impact call. Now, this ATA ROR is limited to patients who have well-differentiated thyroid cancer, so either PTC or follicular thyroid carcinoma. If the histological features of necrosis or high mitotic rate are found, while they are aggressive histology, it's not what's meant by this aggressive histology here. Those patients are then bumped off of this grid. They're diagnosed as having poorly differentiated thyroid carcinoma / poorly differentiated high-grade differentiated thyroid carcinoma. So they're treated as having aggressive disease, and that's what drives the therapy and the prognosis. Okay, so the weight of the reported evidence, supports that tallness is a poor prognosticator. This has been in the literature for a long time, but when you really dive down into the reported evidence, there's really only a handful of studies with outcome using multivariate analysis. So meaning that these are adjusted for important confounders. So really just a handful which show rigorously the impact of this diagnosis on outcome. And as I'll show you, there few of these studies actually have used the same definition. So before we go further, I just want to show you tall cell, and we're going to go over this later in detail. Here you see at low power, some patterns of tall cell. These are tumors which are generally low colloid, they're very cellular. When you see a cellular low colloid tumor, there are a number of different morphologies that can account for that. So that doesn't mean necessarily it's tall cell, but that's the first thing that's characteristic of tall cell variant. Then you go in a higher power and you look for variants which you can sort of take out of this differential. So if it's a solid variant, comes out of the possibility of differentials, or tumors with very cuboidal cells, you take it out. So then you're left with tumors where a tall cell pattern is seen, and you go into a higher a diagnostic mode, and you can actually see the tall cells. So here you see this in the inset. What I'm talking about are tumor cells, PTC tumor cells, where the major axis is 2 times or greater than the minor axis. And so some people will use the cut point of 3 times, some people will use the cut point of 2 times. You have prominent lateral cell membranes, abundant granular cytoplasm. And so I'd like to dive deeper into these studies. Sorry. Ronnie will be talking about a publication of theirs from 2007. And here you see the definition that, that this group was using. And so they limited their study to patients who would have otherwise been classified as low risk. So papillary thyroid carcinomas that did not have any extrathyroid extension. And so that is probably why they saw no difference in outcome. But on multivariate analysis, they did show that this tall cell variant was associated with positive lymph nodes. Now, as you know, one of the major contributions of ATA is the awareness that it's not just a positive or negative call for lymph nodes, but really the burden of disease is what's important in terms of predicting local recurrence. And the burden of disease is defined by the ATA as aggressive lymph node status. We'll talk about that more later. These next 5 studies are all studies which have multivariate analysis and show significant differences in outcomes. And so if you look in the second column here, you'll see differences in, some of them are twice as high, the definitional cut point, twice as high as wide, some of them are 3 times as high as wide. And then the second value is the distribution cut point. So you'll see commonly 50% or more as a distribution cut point, or 30% or more. In this one study, Stenman, and we'll hear more about Stenman later, they actually looked at 10 versus 30 versus 50 versus 70. And here you see the results of these multivariate analyses. So the hazard ratio basically tells you the power of the finding. So for instance, in Axelrod, Axelson, you would see it's 3 times or more likely with this diagnosis that you develop recurrence. In the Detmer article, they found a cut point of 10%, which was significant. And again, more than 3 times more likely to develop recurrence. In Ito, they looked at 3 times as high, and with a definitional cut point of 50%, you have a hazard ratio of over 5. And here's Stenman. When they looked at these different cut points, they found a significant relationship at 70% or more with a hazard ratio around 4. And here's Bonder's study, again, finding significance with outcome according to the cut point. 10% has a hazard ratio of 2, a little over 2, 3% has a hazard ratio of over 3. So it would tend to suggest a dose-related response, which is what we look for when we do analyses. And you could look at this table and come to the conclusion, maybe more is more significant. Maybe the taller the cells, the greater significance. Maybe the higher the cut point, the greater significance. And that might be a logical conclusion. But in fact, there's no data to support that conclusion. Okay, so in this context, I'm going to present to you our study that was published this August on our experience with tall cell variant PTC. And this is our, sorry. I just want to get rid of the view of the authors, the view of the, all right. Well, all right, we'll just go on. So we enrolled all consecutive patients presented with primary papillary thyroid carcinoma from who were presenting for surgery with curative intent from 2017 onward, and patients who were returning to this institution with disease recurrence, where their primary tumors were also available for examination from 2017 onwards, were also included. The cohort was also enriched with patients who have aggressive lymph node status, and that's because that's a particular interest of ours. And so that those were enriched from a personal database of marks from 2010 onward. All slides were reviewed by 2 pathologists, myself and Shabnan Samarkand, and we showed a substantial inter-observer agreement of 73%. We used at that time the standard WHO definition, which was height at least twice as tall as wide, with a cut point of 30%. And so we use these standard definitions: 30% for tall cell variant, less than 30%, so 10 to 29% for tall cell features, and control of less than 10%. What's not in the paper, and what I'm just telling you as an also thing, is that we also did look at the 50% cut point. I didn't put that in the paper because I didn't want to publish. I didn't want to complicate the manuscript, but in fact, all of the conclusions that I show you, we also looked at the 50% cut point and found no association with 50% cut point, probably because it was too exclusive, not enough cases. And so all of the findings that I'll show you are based on a 30% cut point. And importantly, current ATA guidelines were followed for the extent of surgery and administration of radioactive iodine and for clinical surveillance. And at the time of analysis, any patient with less than 6 months follow-up was then excluded from analysis. And so this is our patient cohort, as you could see. I think it's 347. It's blocked here, but it's over 300 patients. And these are the breakdown of the categories. You could see that with this cut point, tall cell variant was the largest group at 185. Patients with tall cell features, 62, and then the control patients were 100. So we looked at tumor size just according to increasing centimeters. And so we found that tall cell variant at 30% was associated with larger tumors, 3 centimeters or more, and with a greater invasiveness. So we looked at all possibilities of invasiveness, starting from intrathyroid, focal microscopic, multifocal microscopic, histological strap muscle. So not PT3, because it was not possible to get all of the clinical features on all of these cases, whether or not they were clinically PT3. So we just defined them as microscopically into strap muscle up to PT4. And so we found that greater invasiveness, strap muscle up to PT4 was also associated with tall cell variant. There was no relationship at any cut point with tall cell variant and aggressive lymph node status. And in terms of our follow-up data, follow-up ranged from 2 months, because one patient died shortly thereafter, to over 200 months, with a mean follow-up of 40 months and a median of 33. So as you all know, one of the features that makes it very difficult to study PTC is the long period of follow-up necessary in patients that can develop recurrence. It's not like the easy days of squamous cell carcinoma, whereas if you have 5 years follow-up, you're done. You know, it's as good as it can be. So patients with PTC can develop recurrence up to 15 years later. And so this cohort just keeps sort of evolving and maturing. Disease recurrence, and we rolled in disease persistence together with recurrence, was seen in 61 patients, a mean of 31 months, and a range that went up to like 12 years. The majority were structural recurrences, with 2 patients having biochemical recurrences. And so here's the results of my Kaplan-Meier analysis. So excuse me a moment. Rats, come on. Ah, excellent. Okay, fine. Okay, here's the results of the Kaplan-Meier analysis. When I looked for features like gender, tumor size, PNI, multifocality, extranodal extension, this had no impact on Kaplan-Meier analysis. And what I did find, which is not surprising, is that aggressive lymph node status, as defined by the ATA, impacted disease-free survival, the degree of ETE, extrathyroid extension, as I mentioned before, with a cut point of microscopic strap muscle up to PT4, not surprisingly, impacted disease-free survival. And then I looked at 3 possibilities in terms of tall cell models. The first possibility here, which is model 2, which is the first thing that comes to mind, would be just comparing outcomes for tall cell variant, tall cell features, with the green line here, which is control. And so that was not significant. That's model 2, not significant. Model 3 is looking and comparing only tall cell variant to the control. And many studies will do only that, and they'll drop out the middle, which is dropping out tall cell features. And again, looking at that model, also no significance. But what we did see is when we group together tall cell variant with tall cell features, so that means grouping together patients that have 10% or more of tall cells, then we have a significance of a p-value of a 0.041 as compared to the controls. So in multivariate analysis, in the Cox regression model, I use this model 1 plus aggressive lymph node status and ETE. And this shows you that in multivariate analysis, it's highly significant that a tall cell diagnosis based on 10% or more tall cells does impact local regional recurrence. So what are our study limitations? Well, our study limitations, as are all the limitations of tall cell PTC in the literature, are limitations in categorization at the defined cut points. Now, this is all done by eyeballing. So can pathologists successfully eyeball between a 9% cut point and a 12% cut point? So everybody will tell you it's not possible, yet this is a potentially impactful call. Here's another issue which is not really discussed in the literature. What about visually estimating the overall distribution of tallness over multiple tumor slides with heterogeneous tall cell component? So if you have a classic PTC with these big papillae and they look like chorionic villi, you can go over, a huge classic PTC, and it's a very uniform distribution, and it's, you can vouch for the fact that it's way less than 10% tall cells. But on the other side, when you have a tall cell variant of PTC, they're not all uniform. They can be quite heterogeneous in their distribution. A PTC can last over 5, 6, 7 slides. The size of each tumor slide is different, and the amount of tall cell in each slide is different. So in this article, we offer a kind of crude workflow based on the tallness distribution weighted by the tumor diameter per slide. And I say it's crude because we're using maximum tumor diameter as a surrogate for tumor area, because currently in working pathology, we don't yet have a workflow for for just an accurate measurement of tumor area per slide, which of course is the surrogate for tumor volume. And that's of course one of the places where computational pathology will take us. Well, limitations of the field. As I've hopefully convinced you, the outcome studies do not rigorously support any one particular definition of tall cell. And that's reflected in this article, in this consensus article from Thyroid from 2017. And what's really obviously needed is a large head-to-head study which would determine the best definitional cut point to predict outcome. So with that in mind, with my working with Scott now for many, many years, and Scott is the PI of our R01 having to do with developing a computational risk model based on the histological risk model. With that in mind, I couldn't help but think, Scott, we have to make math out of a tall cell variant of PTC. And so the promise of making math out of this is by building a computational classifier, we could introduce a kind of reproducibility, a robustness that's lacking in the current eyeball technique. So all pathologists who are making the call of tall cell see something, but the question is, what is it that we are seeing? We're all consistently seeing something, but where do you make the call? So I mentioned before that there's pattern and there's cytology. So again, bringing you back to this slide, you have a very cellular tumor, and this is one of the recognized patterns of tall cell, which is railroad tracks, tram tracks. And again, looking into here, we're seeing tall cells. But if this is 50% tram tracks, is it really 50% tall cells? Not, okay? This is another pattern. There's a general complexity or, evidence of this increased growth that we're not seeing when it comes to the usual parameters of Ki-67 mitotic rate or whatever. But these are tumors that are really growing in a different way than the usual PTC. And it's resulting in this very hyper-complex ribbon-like pattern. These are annotations that were done by Shabnan. And so they're at the same power. On your left, what you're seeing is a very typical classic pattern of PTC. And when you annotate these villi, they look like chorionic villi, these papillae. So you can go through a tumor like this very quickly and with a very good amount of accuracy assure that there's no tall cells in a pattern like this. However, I must tell you, if you look very carefully in there, you will find tall cells. It's just not a tall cell pattern, but there are tall cells in there. Do those tall cells in there actually impact how we make the call, or should they? Okay. Now look on your right and you see corresponding at the same power, this hypercomplex pattern that is seen in the classic architecture in tall cell variant of PTC. And in the bottom, we see her annotations, which look very much like a Keith Haring type of image here. And you can see how these papillae are basically, there's this secondary and tertiary branching, and they're really like growing very closely to one another. Well, where you make the call from the right, from the left to the right, where's that cut point? You can see this pattern, but with spaces in between. Is that tall cell pattern or not? So I'm going to start with our initial foray into building a classifier. And here's what we thought. In our youthful naivete, we thought if only we could measure the tall cells, then we could arrive at a sweet spot. We can change definitions of what it is to be tall 2 times or 3 times. We could change the distribution definitions and find that sweet spot that ultimately predicted outcome. And our approach to that was leveraging the fact that all PTCs will express beta-catenin, have membranous beta-catenin staining at the lateral membranes. Here you see a high power of really nice tall cells. These are more than 3 times as tall with this very strong staining. Well, I had to go through the whole field to find the best example. But when you look at that, you think, yeah, you can make a kind of geometrical map out of tall cell variant. And so our plan was just, detect PTC, detect tall cells, calculate tallness. Pretty simple, okay? And so our first approach was basically using this kind of graphic-based approach and MATLAB segmentation. So this is very different than deep learning. And this is Scott's work. And so the red here is what you're seeing, is just nuclei. This is not specific for anything. And this is just based on the detection of hematoxylin counterstained cells. And the green, what you're seeing, that's specific for beta-catenin. And, when you look at this pattern, it's like, okay, maybe this can be helpful. Now, the issue with calculating geometry is you have to have a closed box. You have to have some kind of rectangle or some kind of closed structure so that you could measure the major axis over the minor axis. And so one of the first things that we did is Scott worked on something called a ray function, which is something that is a function in MATLAB. We also worked on other functions afterwards. I'm not going to show that to you. But what the ray function does is it detects the centroid of the nucleus, sends rays out, and then when the ray hits the membrane, it stops, and it sort of uses that intersection to build boxes. Okay, and so here we are after using the ray function and after cleaning up cells that one was not able to close the box. And again, underneath that, what you're seeing is beta-catenin staining. So it looks like, many of the cells have been captured by this technique. Then when you use your output to calculate major over minor axis, this is what it looks like. It's not a bunch of rectangles like you would hope versus cobblestones like you would hope you would see, but this is the output. So what you see in green are cells where the major axis is more than the minor axis, and what you see in red are PTC cells where you don't have that relationship. Now, look at this overlaid with the original beta-catenin. And you can see here at high power, there's a lot of cells, even here, that are tall cells that cannot be detected by this method. And so that's how you can come to, looking at the left, beta-catenin, where that looks like a tall cell pattern. You go in, high powered, there's tall cells, but the output on the right shows only a 10% distribution of tall cells. Well, again, the problem is it's not so easy to close the box, and cells are laying over one another, nuclei are laying over one another. And in fact, that's what we see when we're looking at histology. When you actually go in and do ground truth annotation. So this is something we did on H&E and something that we did in beta-catenin. And, we all went in there and annotated in these patches in regions that we know by visual examination that these are tall cells. You go in there and you actually, the black line here represents the major axis, the yellow line represents the minor axis. You go in there and you do this very painstaking ground truth annotation, and then MATLAB analysis to see how many cells are tall. And so what you discover is that the ideal measurable tall cells with distinct cell boundaries and non-overlapping nuclei represent just a small subset of the tumor cells in regions that are recognized as having tall cell patterns. So there is this huge element of pattern recognition in our recognition diagnosis of PTC. So what is the importance of detecting geometrically tall cells? Now, we know because of plane of sectioning, et cetera, we wouldn't expect all the cells to be tall, but it's not so simple. Is it the pattern recognition that's driving the recognition, or is it pattern plus the geometrically tall cells? So this question is really uniquely suited for a deep learning approach. And with that, I'm going to, Scott, you just take it away.
Okay, so thank you very much. That's an excellent overview. Just as a little bit of a background, I am, as was stated at the top by Dr. Erkin, I'm not a pathologist. So a lot of what I have sort of picked up over the years has been through these kinds of conversations. And so a lot of the definitions and a lot of the different structures that we're after are coming from sort of these sort of collaborative conversations. So I think it's really helpful for me to sort of hear the way in which these materials are spoken about and the way in which they're used clinically. So yeah, we started out by trying to identify these tall cells explicitly, because that was sort of the initial definition that we were working off of, was this sort of cell geometry. And I wanted to pick up and sort of take this a little bit further into what we're trying now. And the title of this talk is Work in Progress, because it is very much still a work in progress. So when I get to the end and there's not any, whiz bang conclusion, that's sort of why. So we're not the first folks to think about quantifying tall cell geometry. There have been a number of attempts to sort of use computer vision and use automated analysis to try to quantify cell architecture. And this is a paper from back in 2015. This was a conference paper where they tried to segment or approximate cell boundaries. One of the challenges, obviously, is that cell boundaries are not visible or easily visible by the computer on H&E stains. And even with the immunohistochemistry stains that we used, there's just so much noise, especially in tumor growth, and there's these out of plane effects and things like that. This paper showed that they were able to achieve about a 83% accuracy in identifying tall cells, which is fine, but they're still using this sort of estimation. A more recent paper actually looked at doing segmentation. So this is a paper from last year where they used a combination of tumor segmentation, and then they tried to segment these sort of tram track appearance of these collections of cells, and then classify each of these segmentations as being either tall or non-tall. And so when they did this, they're sort of taking a slightly different approach where, again, this idea of, instead of looking at individual cells, they're saying, well, there's a pattern here that is being recognized, and we want to look at the pattern rather than sort of going in and explicitly looking for height versus width. And this paper found that there was a correlation between the automated sort of computer vision tall cell scores and relapse-free survival at certain cutoffs. And so this is representing another sort of, we might think of it as an order of organization or a sort of a length scale kind of approach to defining this morphology. And this actually dovetails really nicely with something that we think about a lot in the School of Medicine and at UB, which is this idea of scale dependence and this idea of, these diseases, these expressions of a particular disease exist at multiple scales and in multiple modalities. And so we want to be able to capture all the variability that could take place across those length scales. So we have these cell morphologies, we have patterns of tissue, and then we have this sort of volumetric sort of understanding of the volume of the tumor that's taken up by the tall cell features. And this is where those different cutoffs come in. These on the right are 4 different whole slide images in our system for the same patient. So one of the big things that we'd like to do is capture this sort of volumetric component of the tumor and the tall cell variant that exists in each one of these and sort of add it up. We also recognize that tumor heterogeneity plays a big role in understanding the disease, both at cellular and pattern levels. And so we want to be able to capture that across slides. And the hope eventually is that this basically becomes a better measurement tool. When we think about computational pathology, we think about AI as it's applied to medical data. What we really want to do is build a better measuring stick that you can use to sort of catalog these patients, and then hopefully that leads to studies where you could look at the cut points in a more rigorous framework, as opposed to, like Dr. Brandwein illustrated, the list of research that goes into tall cell variant is using different cut points and different measurements, and all of these measurements are potentially subject to variability depending on who's doing the study. So by providing some kind of tool that operates off of the images themselves, we can have a little bit more of a consistent framework in which to work. Okay, so our approach is sort of taking the pattern definition. So instead of looking at individual cells, we said, hey, what if we just took patches of tall patterns and non-tall patterns and taught an AI system to recognize the difference between these different patches? Number one, is that possible? That's kind of what we wanted to establish with the current work, is the AI capable of separating out tall versus non-tall patches? And then could we also use this system to sort of try to interrogate the difference between these measured tall cell patterns and this sort of eyeball estimation that Dr. Brandwein talked about? So we'd like to visualize what the AI is doing, and we'd also like to take these measurements, the actual boundaries of tall and tumor, and use those to compare to the eyeballed tallness categories. And again, the hope is that eventually we will have a framework for quantifying tallness at the patient level so that we could discuss this TCV diagnostic criteria in this sort of way. So the data that we used for the initial study involved 67 patients that were taken from Mount Sinai. The patients were labeled on tumor volume of tall cells. And again, we have this 10% and 30% cut points between tall cell features, tall cell variant, and then control or typical PTC. We also have slide level annotations where the slides themselves were labeled as belonging to either tall cell or non-tall. And I'll talk about that annotation in a second. But one of the big things that we do is we have this system set up so that we can manage our slide system and our data. So again, I'm coming at this from an engineering standpoint. I'm very big on data management and how we can acquire sort of ground truth annotations so that we can train our AI. So we have a system that we use called SuniCell, which basically allows our collaborators to upload slides to our servers. It's a web application, or it's a combination of applications, but the one that we're using is over here, this digital slide archive. And so this system is hosted on our Center for Computational Research. And the way it works is we can upload slides to our cloud instance. Our collaborators can log in and see those slides and provide annotations and so forth. And then on the back end, inside the UB firewall, we have a bunch of supercomputers that we can use to run our AI analysis. And then when that analysis is done, we can sort of display those results back onto the system so that we can collaborate and talk about these. So we use this all the time for our computational pathology projects. It's really nice because it allows that sort of remote interaction, and it doesn't require a lot of coding or computational expertise to use the cloud instance. This is an implementation of the digital slide archive, which was not developed by us. This was developed by a company called Kitware in collaboration with Northwestern University. And they basically have this server, which you can see on the left here, which is just a way of organizing our data sets and visualizing them remotely, so that Margie or anyone else can log in, they could see our slides, and they could use those slides to provide us with annotations. And when we say annotations, the way that I think about annotations looks like this. So these are polygons that are drawn with a mouse or with a touch tablet pen. And the blue polygons here represent tumor area in this case, and the orange polygons represent tall cell pattern. And so the first thing that I want to say is that this kind of annotation is very difficult to do because you're sort of being asked to draw the boundary of tall cell pattern. And, you know, we understand that the edge of a tall cell pattern is not always so clearly defined, right? It's sort of a fuzzy boundary or a fuzzy transition from tall cell to non-tall cell tumors. But we're trying to get examples of these patterns so that we can give them to the AI and show them, okay, this is an example of tall cell. This is an example of a tumor area that is not tall cell. And going through that process, you know, with a number of different patches and with a number of different examples, hopefully we can teach an AI to recognize areas of tall versus areas of non-tall. And so I'll go through a little bit about how that works. So the first thing we do is we get these whole slide images. We get the annotations on the right. This is a tumor that is highly, high volume of tall cell pattern. So again, the blue is the tumor area, and the orange overlapping is the tall cell area. Anything that you see that's blue that's not covered with orange is essentially a non-tall area. And so what we want to do is we want to pull out patches from these regions and label them accordingly. So this is what we talk about when we talk about annotations and ground truth. So this becomes the training set for our classifier to recognize tall versus non-tall patterns. And so when we extract the tiles, this is what we look like. Now for this study, we basically said, okay, we're going to extract all these boxes from these areas as long as the boxes are enclosed entirely within the annotated polygons, so that we can be sure that as close as we can, we want to get areas that were designated as tall. So none of the boxes are on the boundary or halfway covered. So this essentially is our raw data that we use to train the AI system. And this is what those patches look like. On the left, we have non-tall cell patches. On the right, we have tall cell patches. And all of these slides were digitized at between 40 and 20x, and we sort of resized the spatial resolution so that we have 0.25 microns per pixel, and each of these patches is the same size, 1024 by 1024. Now, a couple things about this. Number one, you could see that just like you see in real life, the patches are different. They have different levels of contrast and brightness and color. All of these things are really important to a computer vision algorithm, so we need to be able to control for that. And the second thing is that these patches can be somewhat heterogeneous, like over here in the tall cell. Now, I pulled these slides or these patches out at random when I was putting together this slideshow, but you can see here, like this upper right-hand patch was labeled in a tall cell region, but not all of the image itself is made up of tall cells, right? It's not a homogeneous patch is what we would say, but it's still an example that was annotated by the system or by the annotator as belonging to a tall cell region. So this is the way that the computer is going to look at this system. And very broadly speaking, if you're not familiar with AI, you could think of these as like flashcards. And if you wanted to teach someone the difference between tall and non-tall, you would show them one after the other, the flashcards of tall, and you would get them to guess, okay, is this tall? Is this tall? And you would sort of over time correct through this process of trial and error. And eventually the student, or the AI in this case, would get closer to recognizing the difference between these two classes. So that's basically the idea of how we do the training. now going to get into a little bit of the technical detail. I'm not going to spend too much time on this, on how we train the system. But if you're interested, I could certainly, talk at length about how the AI works. We use a deep learning model called ResNet, which is basically a classifier that, given an image, it'll spit out a probability for that image of whether it belongs to one class or the other. And we have about 54 patients that we use for training the system, and that corresponds to about 13,000 tiles, which are split into about 6,000 tall and over 7,000 non-tall tiles. And then we test the system using 27 patients. So we make sure that none of the patients are straddling training and testing. And we have about 1,700 tall tiles in the testing set and over 3,000 non-tall tiles. So when we do the training, I think this might take a second to load up. Let's see. There we go. So when we do the training, this is sort of a schematic of what part of the algorithm looks like. You have a tile that comes in. You basically put the tile into the algorithm, and all of these boxes here are just different calculations that are performed on this tile. And I'm not going to go through what all these do. Again, I can talk about that later. But at the end of the process, so this is a very, very long series of computations. It goes off on the right-hand side, loops back around here, goes through. And then over here, at the end of the algorithm, it spits out two numbers. And these two numbers correspond to the probability of that sample, that input image, belonging to either the tall class or the not tall class. And I'm not going to spend too much time on this. This, again, is how we train the system. These are sort of engineering details. One thing that I do want to mention is this augmentation table, which is basically the ways in which we randomly perturb each training sample, right? So if you're using these flashcards, if you show someone a flashcard of tall cell and then you rotate that flashcard to a human, we instinctively know it's the same class, but the computer doesn't know that, because when you rotate or when you flip it, it thinks it's a completely different image. So we have to show randomly, we flip the image, we rotate the image, we adjust the brightness and contrast to try to account for some of that variation that we saw in the examples of those tiles. So over time, the classifier sort of recognizes that even though it's rotated slightly, it's still the same class that I saw previously. Okay, now this is what the training process looks like. I'll go through these in a little bit of detail. So on the left-hand side, these are what we call training and validation curves. This is the loss or the error of the system on the y-axis, and then on the x-axis is the number of samples the AI has seen. And so the idea is that as you show more and more examples, and as the system trains and learns, that you should see this curve kind of slope down and then level off, which it kind of does. Over here on the right-hand side is a confusion matrix, which shows the validation results. So this is on that validation data set. On the columns are the predicted classes. So this is whether the samples were predicted to be tall or not tall. And then on the rows, this is the actual class, so tall or non-tall. So all of these samples, 12,000 samples, were actually tall and were predicted to be tall. 3,000 samples were actually not tall and were predicted to be not tall. And then these guys, these are the false negatives. They were predicted non-tall, but they were actually tall. And these are the false positives. They're predicted tall and actually not tall. So this is the classification results that we got when we trained our system. And this is okay. I mean, it shows that it's not doing, there's a lot of errors still. We got 500 tiles that were misclassified as non-tall and almost, 180 tiles that were misclassified as tall. But this could be due to those sort of annotation regions that we were looking at before. It could be due to heterogeneity. We're not exactly sure. This is an ongoing process where we're retraining the system, we're re-annotating, we're going back and looking at the annotations we did months ago and sort of revising them. And so this system is constantly evolving using that computational framework we were talking about before. Okay, so I'm going to try and go a little bit quickly through the rest of this because I know we're running out of time. So one thing we wanted to do is try to interrogate this AI. So when we get these results, what is it actually doing? And one way of doing that is we could actually look at the similarity between different patches. And so I'm going to skip some of this detail here, but the idea is that we want to look at the features, the image features that are being used to classify each of these tiles. And so we can do that by mapping this tile down to just a two-dimensional scatter plot where the distance between points in the scatter plot is related to the similarity of those points. So this is what this looks like. So each dot here represents a tile, and the position of the dot is related to the content within that tile. And all the red dots were labeled as tall by the system, and all the blue dots are labeled as non-tall. And so we could see, I mean, maybe I'm being optimistic, but I can see a pretty clear separation between the blue dots and the red dots. You've got some outliers, actually quite a few outliers in the non-tall case over here. But what we can do is we could actually look at which tiles correspond to which dot. And so we can try to look at the content of these tiles and see maybe they were mislabeled, or maybe the system just isn't robust enough to see what the differences are between these two classes. So again, this is an ongoing process where we're looking at this similarity. And then
Scott, I'm sorry, we are running up against a time crunch here.
Sure, understood.
In the interest of time, I think maybe if we could have Dr. Ghossein, I apologize, but have Dr. Ghossein jump in here.
Absolutely.
Provide some discussion, and then hopefully we may have a minute or two at the end here to circle back.
Okay.
Ron, you want to take over the? Yeah, perfect.
Yeah, so you see my screen. So
yes.
Basically, yeah, I'm not going to go through all the slides in the interest of time, but I just want to tell you that since the description of that entity by this pathologist from the Cleveland Clinic, as Dr. Brandwein mentioned, there have always been problems with, it's not moving, let's see. Yeah, always problems with the percentage of those cells. Every paper had a different percentage with the cell height. Is it twice the width, third the width? But to make it clear for the clinician, there is no question that as a group, tall cell is definitely more aggressive than classic. It's universal agreement between all pathologists, and many studies in the 1990s have shown it. Really the rub here is tall cell more aggressive than classic stage for stage. And this has important clinical application. Should you panic if you have an 8 millimeter tall cell variant or not? And that is controversial. Now, Dr. Brandwein and Scott showed in their paper and their collaborators that it is an independent prognostic factors. Now, we did study, I will go quickly through the study just to show you that in 2014 with my surgeon's colleague at Memorial, we got different results, but this could be due to a difference in definition. At that time, I excluded cases with high mitotic count and tumor necrosis from the cohort. We were the only one that excluded them at that time. So what Margaret did to include them was the right thing at that time. But now, as you will see, the new WHO classification, these are separate from papillary carcinoma, even classic or tall cell, because they have much worse prognosis. So just to go quickly here, because we don't want to lose time, one thing we noticed that when it comes to anaplastic or high-grade transformation, if you start with a tall cell variant, with a tall cell with more than 30% tall cells, that's what we define tall cell features, then you definitely have a higher chance of anaplastic transformation. And when we looked at the outcome analysis, and our median follow-up was 9 years, so it was quite decent. Now, the difference, again, with the Mount Sinai paper, that we didn't account for biochemical recurrence because we have cases from the 1980s and some surgeons did not even ask for thyroglobulin levels and so forth. But when we look at it, we found out that there was no impact of tall cell on neck recurrence. I was shocked by that. And there was but there was an impact on distant recurrence-free survival. If you have more than 30% tall cell, it was significant. Other factors were significant when it comes to having distant metastasis, like, of course, if you have a PT4 gross extrathyroid extension or positive margin. But that's really the difference, that the presence of tall cell did not survive multivariate analysis. And when you look at death from disease, having more than 30% tall cell definitely impact worse disease-specific survival. It was actually quite significant. And Of course, other factors impacted that, and we couldn't do a multivariate because in that cohort we had only 6 deaths. But when you look at those who died, almost many of them had either distant metastasis presentation or had transformed in the recurrence setting in a high grade tumor. So this paper, actually what this paper showed is that whether you have 30% or more or 50% or more, it's the same outcome. It's worse than classical. So that's the 30% threshold that came in the World Health Organization 2017, and the upcoming one is based on that data. Now, we, as I said, did not find it is an independent predictor of recurrence-free survival. I have no idea about death of disease. However, let me skip this one. However, I have to tell you that in our studies, we found out that tall cell, I'm talking tall cell without mitosis and necrosis, is responsible for 20% of radioactive iodine refractory PET positive thyroid carcinoma, and is the second cause of death in non-anaplastic thyroid carcinoma, the first being high-grade tumors. So I think for example, the discrepancy between these two studies, as I said, it's the issue of necrosis and mitosis. Also the inter-observer variability, because I used eyeballing and think also it was used in the initial Mount Sinai paper. But I think that's the last slide. I really think that now with what Scott and Margie presented with the AI and a tall cell definition based on architecture, there's really, I'm very optimistic that we will improve inter-observer variability. And also now that in the new WHO, we were able to cluster all this high-grade PTC in different categories, so researchers and clinicians know that it's a completely different animal than papillary carcinoma without mitosis and necrosis. Then hopefully we will be able to have a real idea about the independent prognostic value of this diagnosis. Sorry for the quick talk, but yeah, that's it.
I think clearly this subject requires that we circle back and provide more discussion time. And I think that's something that we will try to target. This has been an amazing overview of tall cell variant and its implications and the challenges associated with histologic analysis here. I think one of the questions is going to be, for me, as a clinician surgeon, is applying new data to that's generated through AI to old definitions of tall cell variants and older studies. And are we going to be able to immediately apply new technology to old studies, or are we going to have to go through this process that's going to require, at least 5 to 10 year follow-up in order to say that AI interpreted tall cell variant means this from a clinical perspective. Margie, why don't you just take that?
Yeah, that's what we hope to do, is ultimately, validate whatever we build on these same populations.
So you think that
right? Yeah. So I would go back to this previous cohort of over 300 patients, and with outcome, hopefully be able to digitalize all of their slides and then compare the performance of the two. That's would be a necessary next step in validation of any classifier.
Right. Okay. So Ronnie, tell me, in your world, is the risk of a community-based pathologist over calling tall cell variant, or is it undercalling?
Good question.
In the past, Mark, it was undercalling. Now actually now I would say maybe overcalling. But what I'm really worried about is the panic, because I had patients calling me of the small diagnosis of small tall cells, like once a lady called me for an 8 millimeter. I think the clinician should be aware that we not choose stage for stage. At the present time, it is worse. So when it comes to tall cells without other aggressive features confined to the thyroid, I think we should not be aggressive. I just want to add one thing, because this session was on pediatric, that we published a paper on pediatric thyroid carcinoma, and we found out, interestingly, that tall cell actually behaves like classic in pediatric thyroid carcinoma, and this is fascinating. We don't know why. Maybe some of them don't have BRAF actually, but they really look like tall cell. That will be another interesting thing.
So I'm going to ask you all one question as we wrap this up. Do you think that in 10 years, we will be discussing tall cell variant as a prognostic feature? Are you confident about that? Or do you think that this discussion, because of the challenges of concordance of interpretation, will be minimized 10 years from now? Ronnie, do you want to take that?
I think 10 years from now, we will have the answer whether tall cell is a independent prognostic factor or not. And we will have solid data. My feeling is that actually it will be especially in cases that are where the tumor went outside of the thyroid. But this is an impression, and we have to prove it. I mean, this is backed by nothing. But I think we will have the answer, which is the most important thing.
Yeah, I think in 10 years, we'll have plugins to make our assessments more reproducible, more accurate than eyeballing. And, we looked at intrathyroid tall cell as part of our group, and was not enough data at that time to show any differences. So I agree with Ronnie's impression, but again, we didn't have any data to back that up.
Great. Listen, I want to thank everybody on the panel for your outstanding presentations. I commit that we will come back to this topic and engage in greater in-depth discussion. Once again, I want to thank all of our viewers for joining us on this 3-year celebration. And this is certainly a wonderful session to have celebrated that 3-year anniversary. So as next Friday, I will actually be hosting this with a panel of experts on a series of discussion, or in a series of case presentations with colleagues on related to some really challenging cases in invasive thyroid cancer. So with that, everybody stay healthy. And I commit that we will come back to this topic and allow a much greater in-depth discussion. Thank you all.